commentary.
Great, thanks for having me. Two things. One, I'm Greek, in case you haven't figured out by the last name, so it's going to be very hard for me to sit still in a chair and talk. And two, they told me no slides, and I'll explain why that's a problem in a little bit. I actually want to talk about this perspective from an analogy or a metaphor that keeps coming back up, which is this idea of violence as a disease. And I actually want to talk and take a step back about what that would mean, not just for research, but for practice, if we actually extended it beyond this metaphor. And the metaphor is clever, right? And it actually makes sense. And I'm going to be a person that says that violence is contagious, specifically gun violence is contagious, for particular reasons. But I want to go through this quick exercise because one of the things we do know about gun violence in particular, which is sort of my area of expertise, is that the more focused the intervention, the better the effect seems to be, particularly on urban gun violence these days. And that's a very different type of disease. It's a very different type of intervention. So first things first, what type of disease is violence? Now, my experiences with gun violence, typically homicide, but also sort of the almost homicides, and there are about 5 to 1 of those. But it's before we can actually talk about this evaluation, we need to figure out what type of disease is violence, how does one catch it, how does it spread across a population. And here is one of these particular instances where we have a theory. Basically, whatever the type of violence, the theory situates around risk factors. Too much of this, too little of that means more violence, right? In my instance, in my field, it's too much poverty and inequality. Too little social control and social capital means your rates of violence go up, your individual risk of victimization all goes up. One of the things I think it's important to think about this analogy a little bit more closely and push it is, in particular, is the type of violence we're talking about, is it an airborne pathogen? Is mere exposure enough for you to also become sick? Or conversely, is it a bloodborne pathogen, right? Which means something different. In my instance of the work I study, urban gun violence, I would argue it's a bloodborne pathogen. You don't catch a bullet like you catch a cold. In fact, the things that put you at risk above and beyond these risk factors, which I'll come to in just a second, are very specific types of behaviors and interactions. And one of the things we know when we talk about risk factors is we know the buckets, and everyone's mentioned them over and over and over again. And we looked at the astronomical rates that Dr. Rosenberg put up there, and we were all appalled by those, as we should be. But the truth is, in most communities where these risk factors are high, the vast majority of people don't get shot or don't shoot anybody. It doesn't mean they don't experience it, which is a different type of exposure, but it means they themselves are not personally shot or they themselves don't shoot anybody. The application of social network analysis, and part of this work I'm actually doing in the evaluation of David Kennedy's models, actually takes this idea of a bloodborne pathogen, this idea that it's transmitted through risky behaviors in a very serious way, which is we look at where, using network analysis, those little dots and connections, and everyone's seen these figures in social media, to try to understand how violence concentrates, and importantly, what types of behaviors put you at risk, like sharing needles, like unprotected sex. What types of risk? And if you look at something simple, and if you think of some of the numbers that the last panel talked about, these idea of being arrested. Well, being arrested gets you in trouble. It's a sign of a risk. It's actually a conservative sign because most behavior is not reported. I have a paper that's coming out in November in AJPH. We do this in Chicago. If you missed the last, 20 years, Chicago has a violence problem. I looked at the west side of Chicago, which is the highest homicide rate in the city. When I say high, it's 55 per 100,000. So the national average is about roughly 5 per 100,000. It's 55 per 100,000, predominantly black, about a third below the poverty line. You name the risk factors. When we look at these social networks, we see that 70% of all homicides and 75% of all non-fatals, including domestic, occur within a social network of about 1,600 individuals. That's 5% of the neighborhood population. We did this in Boston, in the Uplands Corner community, 763 individuals, 4% of the population, 85% of all gunshot violence. More importantly, to talk about contagion and how it spreads, indirect exposure matters. What we look at within the social network is every handshake closer you are increases your odds by almost 37%. So if you have a friend, just having a friend, and I think of the story of David, I know I'm going to get shot. And that's actually the case, except most of these individuals and their young men, they don't know just one person who's been shot. They know multiple individuals have been shot. These findings that we're looking at, we're replicating in other areas, but the point here is understanding how the pathogen travels through risky behaviors, changes what it means, gets beyond risk factors, and rather than just having buckets and a profile sheet, you can actually have names of individuals who we already have our hands on in the criminal justice system, in the health system, in the school system, and you can divert resources before a potential event. Okay, number two. So number one, what type of violence is it? Number two, not all violence is alike. You know what's not like the violence I study? Child abuse violence. In my case, victim and offender, there's a lot of overlap. That's not the case in child abuse. And even in a lot of the communities where I'm working right now, there's subsequent longitudinal effects, which we know very well. But in terms of who's getting shot today, a kid doesn't have the same dynamic with an adult as two young men or a young man and a young woman, domestic abuse. By the way, that other 30 to 20%, those are almost entirely domestic cases. Stray bullet killings and stranger ones. Okay, so not all violence is alike. Diagnosing and treating violence, and again, not to go back to some of the things we've already said, but along with Jens Ludwig, who's a new member this year, who's not here, we wrote a report for the Biden Commission talking about this issue of funding at NIH, and we ran a few numbers, and between 1973 and 2012, the NIH funded 486 research awards combined for cholera, diphtheria, polio, and rabies, for a total number of cumulative morbidity of 2,068 cases. And then we have 3 grants for firearm violence with more than 4 million total injuries. But why does this matter? Because we have trash data when we're trying to count things. The part of the reason we rely on homicides is because that's better than the other data that we have. When we talk about, and this has been a constant theme as well, joining public health, public safety, education, we still are relying largely, for some of us, on criminal justice data, which is notoriously bad and biased in ways that we know and understand. So another sort of element here is to sort of figure out how we can diagnose and get better at data. And last but not least, evaluating our efforts. This is what it's about. One of the things from particular areas of gun violence and homicide and assault are that the more targeted approach tend to be more effective for a couple of reasons, one of which I want to throw out there because it shifts the policy debate, is because it actually means you have to care about people we don't usually care about. Everybody wants to save school kids and old ladies, and I like old ladies and kids, but you have to actually have interventions and policies and tactics that respect largely young men with criminal records. We actually have to want to save their lives. And when you do more harm as well as, do less harm as well as more good at the same time, we can avoid certain types of evaluation, or certain types of interventions like mass incarceration, which we know all the horrific consequences on health and beyond on that. So,
thank you.